Hello, friends. Welcome to the YouTube channel of Life and More. Today we have Mr. Deepak Sharma with us. He's the co founder and CEO of MedLern. MedLern is a digital learning and training platform purposely built for hospitals and healthcare professionals. Welcome, Mr. Sharma.
Thank you so much. Glad to be here.
It's my pleasure to. So, how did you think of starting MedLearn? Why did you begin MedLearn? And when did you do it?
No, that's a very good question because a lot of people ask me that. It's a, we have a parent company called Impulsis, and Impulsis has worked for 25 years in a lot of medical and healthcare training and research and academic platform, building digital stuff globally for, the likes of Walters Kluwer, Elsevier, American Heart Association, Medical Association. At some stage, we also started building simulation systems for the American Heart Association. There was an unfortunate time in 2012, I think. One of a very young employees we lost on the dentist chair for a medical error which was avoidable. He was 22 years old. He went home to Kerala for a minor dental procedure and he died on the
Mhm.
chair. And that's when Samir, my co-founder, decided this was it's a very young life loss. So we actually instituted an award, Dennis Sunny Award, because he was a very jovial guy. But then we also
Mhm.
decided we're doing so much globally. At some stage, we need to see what we can do for our society. Both Samir and I have a family full of doctors, although we're not doctors ourselves, and we feel very
Mhm.
passionate about it. So that's where it started. Eventually, of course, other priorities took over, and the market also wasn't ready. But we started just around COVID. Didn't
Okay.
know COVID was coming, but it was obviously good timing for awareness. But it took us a year to get traction.
Okay. But if I may ask you, what happened to that person what happened actually that he passed away on a dental chair?
I think there's some kind of anesthesia if you get the dosage wrong or something.
Okay. Okay.
I
So
think
then, how did you like proceed further? You started MedLearn.
so. We
How
actually were
was the?
conceiving. Yeah, we were conceiving this at that time, but as I said, that time it was a bit early, and we were building
Mm,
our ecosystem of a lot of knowledge-based providers all over the world, and we built digital solutions for the last 25 years for healthcare.
mm,
Uh, but around 2020, just before COVID, or maybe it's at late 2019, we wanted to take this off. We built the platform and we had a lot of partnerships from across the world for content, for curriculum. And we decided to go ahead at that time. We have
mm,
had some of our global partners, American Heart Association, Ladle, the Norwegian firm. They've come on board
mm,
as well. They are board participants in MedLearn.
mm,
And we launched
mm,
at that time, we looked at the Indian hospital specific needs because while what we were building all over the world was really needed a lot of customization and adaptation. Processes are
mm,
different, workforce is different. So I think
mm,
it took us a year and a half to just adapt all our learning for the Indian environment.
mm,
And we still continue to adapt. 5 years
mm,
in, and we're still sort of experimenting with something works better in India, Indian language stuff, the way Indian, work environment is, Indian legal and compliance systems, right? So
okay.
we adapt
So
a
what was
lot.
the response?
Yeah, go
Yeah.
ahead.
What was the response of hospitals at that time? Were they open to it?
That's been a long, long journey. So
Mm,
the as I said, this was COVID, so everybody
mm,
felt the need because even the basic training wasn't really happening, right? But also
mm,
it was the
mm,
wrong time
mm,
because they were just busy saving lives. But somewhere I think the messages started sinking in.
mm,
You don't build a sort of fire escape. Well, the building is on fire, but that time the building was on fire, right? But at
mm,
some
mm,
stage, we got a lot of appreciation for what we started. But the actual conversations around adoption, etc., started only about a year. So first 12 months was just building awareness in the middle
mm,
of COVID, right? And it
mm,
was obviously
mm,
saying, yes, we should have done this, but right now we've got to fight other fires.
mm,
But
mm,
it's still quite challenging because hospitals come at it from different places, saying, how does it affect my workforce? How does it affect my profitability? Is my
mm,
culture adaptable? Do I need to do this just for
mm,
compliance? Right. So there's a whole lot
mm,
of still ifs and buts, but at that stage, it was just awareness building for the first year.
mm. So what is the in your like in the last 5 years, what do you think you face the biggest challenge in training doctors, nurses, and other frontline staff? What has been your biggest challenge?
Okay, so I can't. So since you mentioned three, four different categories, and we go across the
Mm,
board from the
mm,
ambulance driver to the surgeon, right? So
mm,
challenges do differ. Challenges differ by
mm,
region, which part of the country we're working in, size of the hospital,
mm,
and obviously the
mm,
kind of staff. But across
mm.
the board, what we've feel in a general sense, at doctors level, there's a little bit of a uh, cultural shift that's happening, but a lot of doctors are consultants, right? So, as an organization to say you must train, you need to have more control, right? So, it's fewer organizations who can drive that culture unless all the doctors are full-time employed. Many of them are consultants, right? So, that's been a
Mm,
tougher
mm.
market. Nursing, again, we see a lot
Okay.
of eagerness to learn, but there's a always a
Mm,
uh, challenge. Initially, it was digital adoption because there is a phase where it's good to shop or do social media on the phone, but learning takes a bit of while, and most hospitals don't have a lot of laptops
mm,
and stuff. So we adapted.
mm,
Language was an issue. Right? Doctors, everybody knows English, but nursing, depending on which part of the country you go to, the familiarity with. So we've adapted now. We are in 8 different Indian languages even for nursing. Plus, we
okay.
had to simplify a lot of stuff, which was to say, we built micro learning courses, which is like literally gamifications. You have learning modules of 1 or 2 minutes, which in the morning, just building a culture. Uh,
Mm,
and of course, there's a lot of different aspects. There's digital skepticism initially, there is language skepticism, saying you just can't learn digitally, you have to have in person also. We actually do agree, and we built that also. You can do in
okay.
person training, so using the system and keep record keeping and assessments.
Mm,
Simulation, which is actually using your hands on devices and mannequins, right? So you get a practice. So we
mm,
built a whole lot of complex solutions uh,
mm.
based on what we've heard.
Okay. And you said that you are in eight Indian languages. The training modules are available. What are those? And also, uh, what all states are you present? Are you
Oh, we
across
actually
India or?
Absolutely. We're practically, I think I don't think, even in Northeast, we have quite a few hospital been onboarded. I can't think of a single state where we don't have uh,
Okay.
an existing hospital. Some are small, of course,
Mm,
some are large. The
mm,
languages we picked for the initial set was to give as much of a coverage, which is so up north, Hindi, Gujarati, Marathi, and Bengali, and then the down south, the four big languages, which is Kannada, Tamil, Telugu, and Malayalam. And we
mm,
built both soft skills content, we've built nursing content, and we've taken a lot of care that nothing is lost in translation, nothing
mm,
technical is misinterpreted, but also that the Hindi
mm,
is not very complicated. It is generally what we speak every day. It's resonating
mm,
really well because there's some challenges even in soft skills like
mm,
conflict management, communication management, management self, right? And this
mm,
arises in any busy organization. When hospitals, a question of patient safety, right?
mm,
We have very specific hospital-based case study scenarios in these languages, saying how do you manage teamwork in a hospital to make sure patient care is not compromised? How do you overcome differences and adapt to change? So yeah, it's
mm,
across the board, soft skills nursing.
mm,
Operations.
mm. You're not there in Punjab,
Yeah, they're in Punjab.
so you have the module in Punjabi? No.
Punjabi we don't have because we feel Hindi works, but that's the next step, right? We have
Acha.
to first cover what is the Pareto principle, like cover 80-20, right?
Mm,
Hindi
mm,
does work in Punjab, but yeah, obviously there's a next step, right?
huh. All the vernaculars, languages that you plan.
Yeah, slowly, but
Oh,
we just sort of now rolling this out for the first eight, which covers 80% of the population. And if you go,
mm,
Hindi is understood up in the north, east, and west, right?
mm, Hmm.
So we
Hmm.
started there. We have some really good customers in Punjab, SPS, Alchemist. So as we go, we will definitely look at that.
Okay, okay. And how do you think that this continuous learning program, continuous training programs improve patient safety? And are there any specific cases where the clinical outcomes have like become better uh, after the training and all? If you could cite some
Sure,
example.
sure. So there are a couple of things. One is, the idea about continuous learning. One is that the medical knowledge changes so fast, right? Somebody was
Mm,
giving the statistics. I haven't obviously, but it's about 50 years back. It took 60 years for medical knowledge and research to double. Today, it doubles in 73 days. The amount of new research, protocols, drugs, treatments that are
mm,
coming out, and how do you simplify that? How do you make sure the right thing is available? And people are updated, right? They're not really diving in deep or working with outdated knowledge. So, and given the environment is high stress, you can never have a comfortable staffing level in a hospital. Everybody's always short staffed. So continuous
mm,
learning is the only way people can learn on their own time for 50-60% stuff. Obviously some things need person to person training and coaching and oversight. Some things need, but there's a lot of continuous learning that can happen as and when an employee has the time flexibility. So it has to be very flexible. It cannot be very rigid classrooms, or I
mm,
mean, you have to apply the right. So to answer your question about two things, safety and clinical outcomes, I think there's both slightly different aspects. So safety, for example, if you see in a dialysis chain,
mm,
there is a lot of uh, handling of the equipment and back to the patient, etc. And the hygiene protocol is very complex. Every time you touch a machine, you need to hand wash again, right? And sometimes reinforcing that, defining the process gets missed. So if you see in most dialysis chain, the norm is that patients who unfortunately get hepatitis B because of the infection control issues. This is almost like, unfortunately, a given that hoga hi, right?
oh,
But what we did with NU, which is a chain based in Bangalore and Karnataka, is they defined the protocol. We had a continuous, as you said, uh, they've got hepatitis B down to zero. In fact, we have a case study out there. They published this thing.
okay.
They one of those things where the patient safety is dramatically improved because you can continuously reinforce and retain the knowledge. Actual clinical
Mm,
outcomes is a slightly different example.
mm,
There are two resuscitation solutions from the American Heart Association that, since they are partnered with us, we provide. This is BLS, Basic Life Support, Advanced Cardiovascular Life Support. So, actually, sometimes
mm,
you should see this is a brilliant solution, right? Normally, ACLS, BLS take 2 days of in-person intense training. You do the resuscitation on the mannequin, you do compressions, airway
mm,
management, and then it's
yeah.
still left to the instructor who are experienced to say, is it being done well or not. But
Mm,
HA and Daryl developed this amazing platform. This is wired up with sensors, and so the mannequin is a human-like device. And as the
mm,
student practices, it gives you very precise feedback if your compressions are not deep enough or fast enough, right? Or your airway
okay.
management, how much time you're doing. It gives you real-time feedback and gives you a graph saying, and it does not pass you until you pass with 95%, right? And that means that, and that you can practice anytime. It's not just if you do
Mm,
BLS, you do once in 2 years, and when you actually have an
mm,
emergency, your muscle memory is weak. Now, with these
mm,
solutions, I'll send you a clip sometime. You can literally
mm,
have somebody train on their own, and because trainers are also very few, you can't have good trainers everywhere, right? So
mm,
then the students, doctors, nurses can come in anytime, day and night, practice as many times as they want. Actually, research
mm,
shows that the more you practice on your
mm,
compression, uh,
mm,
when an actual event happens, you're better
mm,
prepared, and the recovery, the actual success of resuscitation is much higher, right? This research
mm,
shows.
mm.
And that's the solution. It gives you very precise feedback, gives you the opportunity to practice
Mm,
stuff, which is not possible in a standard classroom
mm,
environment. You study for 2 days, you practice for 2 hours,
mm,
and then for
mm,
2 hours, for two next 2 years, your certificate is valid,
mm,
but you don't really see to practice. So that's an example of clinical outcome. Actual recovery
mm,
is better.
mm. So your training modules that you give, do you give certifications also to
Yeah. So
the
we have
participants?
yes, yes.
Mm,
So we have certifications which are medicine certifications. We are
mm,
actually partners also, Layer to LHA. They provide the certification which is valid globally.
okay.
We're
Mm,
working on some of these with the Healthcare Skills Sector Council to get these validated. We're still in process.
mm,
The other interesting thing is many large hospitals, because when they
mm,
create internal programs, you can put them on MedLearn, right? Because it's just a system also besides the content. So they
mm,
can actually create their own internal certifications to encourage employees, right? Which works
yeah.
out to be, in some cases, a little more cost effective. They're confident and they want to encourage the
Mm,
employees with achievement. So many hospitals
mm,
actually use our platform to create,
mm,
I mean, they use our content, third party, but also they can, for
mm,
specialized roles, yeah, they can create their own certification programs saying,
mm, mm,
at the end of a year, if you complete all of these, you get a certification from the hospital.
mm. So which are the hospitals that are actually doing this in India?
Quite a
Like,
few, actually, quite a few.
mm, mm.
We have, you mean in terms of certification,
Yeah, in
or
terms of certification.
MedLearn has about
Like,
450 hospitals all over India right now.
mm,
And
mm,
150,000, 1.5 lakh healthcare workers are getting trained in these hospitals.
okay.
We have very large hospitals like, you know,
Mm,
Go, Motherhood, Nova, etc. We have changed like Yashoda,
mm,
etc. down south. But we also have smaller hospitals. We have in tier three cities, Sholapur, Ashwini, tier two,
okay.
Chandan Hospital, Lucknow. So they're like, and many of these, I can't say specifically which ones, but many of these have decided to encourage some of their staff built internal. For them, it's also career progression because it is a big challenge with
Mm,
attrition and staff turnover. So they
mm,
create these programs to identify, their promising young talent. They will create a
mm,
certification. They will
mm,
also reward them. But if they train successfully for 12 months, you get a certificate, then it counts towards your, future career prospects. In that sense, it also builds up future talent pool for the organization. So many
mm,
hospitals are
mm,
encouraging that also.
mm. You talked about tier two and tier three cities. How are the hospital placed in these cities as compared to the tier one metros?
Okay. So actually, interestingly, we have quite a lot of presence in tier two, tier three cities. But over the course of last 1 year,
Mm,
Medlern worked with, Nat Health, which is the national body for healthcare organizations.
mhm,
We went
mhm,
to 12 different cities, by design, smaller cities, somewhat,
mm,
like
mm,
Raipur, Indore, Bhopal,
mm,
and Rajkot, etc. And we got smaller, mid-sized hospitals, CEOs, owners together, and the agenda
mm,
was to see how well they are digitizing, right? Not necessarily
mm,
training, but overall EMR adoption, HMIS adoption, right? And
mm,
the idea was to encourage this on behalf of the government. Government's trying to do ABDM where all hospitals can get connected. And we
mm,
found that across the board, the awareness about new technologies is
mm.
fairly high, especially among the doctor and
Okay.
hospitals. Yeah, and the
Mm,
desire to adopt is also high. But the uh, the challenge sometimes becomes the availability of skilled people to implement those systems. But they're very curious about artificial intelligence, right? They are very
okay.
curious about training, right? But they
Mm,
also realize some of the smaller hospitals, they don't have the training infrastructure, like they don't have an L&D
mm,
department, right? So
mm.
that's where we also come in. Most of our hospitals, we almost have programs that they can manage from Bangalore. We have a success team. So we encourage
Okay.
them to literally saying, we will manage this for you because it's managed digitally. So,
Mhm,
for a 100-bed hospital, 150-bed hospital, even 50-bed hospital, really
mm,
having a full-time learning and development team is difficult, right, to
mm,
justify.
mm,
So, but the desire is there. It's just
mm,
that kind of priorities differ, right? So many of them, as I said, they are looking at cultural change. They're growing and expanding because these cities' economy is growing, insurance coverage is growing, right?
mm,
So they've sometimes they've focused more on soft skills, sometimes, but they've identified issues and they're growing to saying they have standard things, right? If I'm opening another branch, I want the experience to be common, which is very well accepted fact in larger chains. But even in smaller
mm,
hospitals, smaller cities, you will see that they
mm,
will say, I know that if a patient walks in here and their patient walks into the other unit across town, they should have a similar experience. So that awareness
mm,
is there. A lot of awareness about
mm.
NABH accreditation, right?
Okay.
And that's catching up. And
Mm,
that's where we come in majorly because a lot of the NABH requirements are standardized training on almost everything, right? And to be able to show
mm,
that, uh, that's where the hospital sometimes they start with that side saying, my focus is
mm.
NABH, right? So we start there and then they move on to soft
Okay.
skills and patient safety. So depending on where they are, but the appetite's there, the desire to
Mm,
I mean, business-wise, do a better job and also provide
mm,
better service to patients
mm.
is there. It's just
And what about, yeah, and what about rural areas? Are you present there?
not really because
Mm,
it's hardly seen as a lot of the we've yet to work in a big time with the government, right? Most of the rural areas covered by
mm,
the government sector, right? But we are
mm, mm,
starting to work there in the government of Karnataka in some places, but
mm,
we haven't yet gone there. We are looking
mm,
at some solutions because of the language, uh,
mm,
etc. is different. The kind of medical infrastructure is different too, right? Digital and otherwise.
mm,
Uh,
mm,
and also the staff. So if you just have a primary center, the training needs to be different, right? So we're
mm,
working on that, but so far it's not been a big priority because eventually the
mm.
referrals for the serious cases will come to the district hospital, etc. We
Ah,
feel we can do a better job.
okay. Okay. And uh, based on your journey across the IT and the healthcare sectors, what leadership principles are most critical when you're building solutions for complex healthcare ecosystems? What do you think is important?
Yeah, it's complex. Very good point. It's complex and shifting, right? It's not staying the same in India. So the
Mm,
I would say one is to really not assume that what works another part of the world will work here. You have to work closely with an ear to the ground and really keep testing, speak to your customers, saying, uh, you know, is if these solutions right and make changes. Uh,
mm,
Also, the because of the evolution, you have to be able to change very rapidly, right? So whether you use technology for that, a sense of agility, saying something is shifting, government policy shifts, right? You have to adapt fast, right?
mm, mm,
Uh, and that is really something you can take the basics of things which have been built, right? So things which don't change clinical knowledge, standardized protocols, etc., etc. But when it comes to user behavior, business processes, right? So as I was talking about digitization, uh, you know, in general, we see a lot of diversity in the same room, in the same city, 20 hospital leaders sitting there, they're tackling the same problem differently because they're so I think your solutions need to be configurable, customizable rather than you can't build one for everybody. So I think
mm,
technology is also ready for that. I think cloud-based solutions allow you to do that, right? So you can
mm.
build a core and then say you can configure it, but it is
Do
complicated.
you
It is more complicated than anything else I've done before.
okay? Do you think that having a doctor, like an actual doctor, a medical doctor, as the CEO the top boss of a hospital helps you uh, get into that hospital better, or other people from like CEOs and top bosses can be from any field, no? They're not necessarily doctors, medical
True.
doctors.
You're
So
absolutely
how do the two, like if there is a hospital where there's a doctor and there is a hospital where there is a person from non-medical background. So how do these two situations differ
so
when it
from my
comes to like
perspective, yeah. So, from my perspective, from adopting digital training or any other digital process, it is
mm,
not so much as what their formal education has been, but what their mindset is, right?
mm,
People, if they're doctors who can have very deep discussions about what's happening in artificial intelligence, right? And
mm,
they're aware of technology, they know the benefits of putting a digital EMR in place. They can really get
mm,
hands down and, I mean, really ask you deep questions that you have to answer if you want to convince them. They're very hands on. Uh,
mm,
and you have similar things with professional CEOs or amazing hospitals. There's, you know, I can give you examples of hundreds of each, but there's Bethany Hospital in Bombay, which has been run by a technocrat. It's a mission-run
mm,
hospital, but you should see the amount of focus. And Mr. Vijay Lakka is not a doctor, but he's
mm,
so hands-on, and he can literally have a conversation. And he's got a both management insight, medical insight, technology insight. So I would say it's more about the attitude and rather than their formal call. And they're doctors who can really, as I said, hold their
mm,
own. They know they can talk about AI, what's happening elsewhere, how is it relevant here, and therefore a very forward-looking people with clinical backgrounds as well. So I don't know if it's a factor, but it's more
mm.
the kind.
Okay. Okay. Have you met with resistance from any hospital that you've approached? Have there been any resistance to the training?
Yeah, so the resistance comes in different shapes, right? One, as I said, is there are very few hospitals who say we don't believe in training, right? Uh,
Okay.
I mean, there may be some one or two might say if I train people, then they will go or they will become more qualified. But most people understand it's a very short-term view, right? So the standard answer to that is, what if I train somebody and they leave? Then what if you don't and they stay, right? Then you have a bunch of unqualified, risky people on your staff. So there's no option really. But
Mm,
I don't think that's a very widespread attitude. The
okay.
challenge is the resources. The
Mm,
challenge is demonstrating what works in the Indian environment because it's a new idea.
mm,
We are, unlike a different market where, in the beginning of the year, hospitals have decided or any business decided, I want to digitize my EMR or my OPD, and I will have a budget, I'll have a timeline, I have a project, what will come. When we go in 99% of the time, uh, we are going in, educating, building awareness, convincing, creating budgets, showing them the benefit. It
mm,
literally at the first step of creating a new market, and
mm,
it's very challenging, very satisfying. But I think the hospitals who ask difficult questions are not the ones who don't want to train, but they want to make
mm,
sure that uh, what they're going to do is going to be effective. And since it's the first
mm,
time, uh, they have questions. And many hospitals, we like struggled initially because changing the culture is tougher, right?
mm,
Say if you're training, but if you don't say connect it to your performance management, how it affects your progression, it's slower to
mm,
adopt, right? If the management doesn't communicate again and again, saying this is important, it is slower to take off. So at a leadership level,
mm,
we face a lot of grilling and questions. And yeah,
mm.
if everybody was just adopting it, we would be in a different place. But we're
Yeah.
getting there. We're getting there.
Mm, mm. Revenue must be, they must be facing the problem. Many hospitals may be facing the problem due to the revenue.
Not really. So this is the interesting part. We made
Mm,
the solution really inexpensive. I mean, I
mm,
can do the numbers saying it is like you know, one cup of tea is also like 7-8 rupees per employee per day is the cost, right?
Oh, okay.
So if earlier we worked with cloud, we worked digital, that is the thing in a scale you can bring down the
Hmm,
cost, right? But
hmm,
obviously
hmm,
keep creating more content. So
hmm,
does come up in conversations or the budgets, etc., because that's a normal business. Nobody says I've got all the budgets in the world, but
hmm,
I think it's a value. Demonstrating the value takes time compared to the
hmm,
revenues. To be
hmm,
honest, any hospital, even if it's a small 50 to 100 bed size, they got 50,
hmm,
60% occupancy. If they're well run in any city, they can easily afford a solution at this level, right? But it
hmm,
just our challenge is to say, demonstrate the value. I don't
hmm,
think these solutions are expensive. A lot more money is being spent on, building, fancy buildings or buying equipment. This is your most
hmm,
important asset, your people. This is how we position
hmm,
it. And this is the investment is literally less than 10 rupees per employee per day.
hmm. So, what changes do you think are essential for strengthening the healthcare delivery and wellness outcomes in India vis-a-vis other countries? Like, what is specific to India and what is common to all?
So India is not unique, but uh, slightly different in most of the other markets, right? The government is a big player, right? Private sector
Mm,
is a bigger player. Private sector, this is interesting. It's very fragmented. Top 10% bed capacity, top, the big hospital chains are just top 10% of the 90%, like smaller hospitals. So it's a long tail of providers, right? So that's got to be hard to standardize and monitor and regulate and stuff. So that's the actual provider side, right? There's government, there are large players, there are smaller players, right? Now look at the payer side, right?
mm,
Again, there is government which now pays for PMJ mission, right? For the poor people. So there's similar things which exist in different parts. Uh, let's
mm,
say US has Medicaid, right? For the economically disadvantaged people, but we have
mm,
a very interesting mix. We have uh, government provided insurance, not just to
mm,
CGHS but also for people. We have private sector insurance, which is sometimes provided by employers. It's
mm,
growing trend, right? If you looked at it 15,
mm,
20 years back, right? And they can buy private life as an individual now, which is also catching on last 10 years.
mm,
And there's a lot of cash and out of pocket segment. So given the
mm,
size and diversity, that is a very complex market landscape, right? So when you try and say either digitization or what you say, what government is trying to do, Ayushman Bharat Digital Mission, connect all the hospitals so they can share data with security, so the patients benefit, right? So that becomes a very challenging problem. You have to find
mm,
solutions and you have to get everybody to agree, right?
mm,
So in that sense, it's a complex landscape. Whatever change you're trying to do, right? Whether you're trying to
mm,
regulate, you're trying to, uh, you know, add, say, allied health professionals as a find board. Every state has to have a board and regulate them. Licensing is different.
mm,
We are the largest population in the world now. China, we have so much more
mm,
diversity, have more diversity than Europe within the country.
mm,
Uh, we have gone through an era of completely private sector than nationalization. Not, I mean, in certain industries, uh,
mm,
going now, but it you can look at parts of it and say, okay,
mm.
UK is completely government, almost Canada is completely government. These are the things you can learn from there.
Okay.
When it comes to the
Mm,
private sector, it is obviously regulation becomes a lot more important. So the challenges are different.
mm, mm, mm. So one question: how is AI helping in the medical field? What do you visualize, and what you visualize it will do in future? What it is doing now, and what it will do in future?
Okay. Let me take that in two parts. One is a very
Mm,
small part of what I do, which is learning and training. We're already using a lot of AI, right? Because not
mm,
everybody is at the same level, right? So if you
mm,
can use AI to develop personalized career paths for them, right?
mm,
Uh, Really give them exactly what they want at that stage, right?
mm,
So that their AI comes in very handy, and we're building that, planning, training, delivering content, etc. Also assessments,
mm.
right? There's solutions which will look at, we are trying to bring them in. So but it's already happening in other parts of the world, that if somebody
Okay.
is performing a practice on a mannequin, the
Mm,
camera capture can analyze whether they're doing things right or not, right?
okay.
You don't need a trainer to sit there and saying, oh, you did this wrong. There are 42 steps in cannulation. The video
Mm,
capture camera AI will go and say, so I'm talking about training and skilling. But if your
mm,
question is about bigger part of healthcare, that is going to be big changes, right? So
mm,
in a nutshell, the final holy grail is personalized precision medicine. So if four people have the same disease, diabetes, uh,
mm,
personalized precision medicine means that treatment for everybody will be slightly different or vastly different because their genetic makeup,
mm,
their lifestyles are very different. Now, to devise that, obviously, you need a lot of AI, right? So the minute
mm,
somebody
mm,
comes in and says, "This is the profile, this is my genetic test, etc.," which is the
mm,
best solution. It is not one size fits all. So you'll have much more
mm,
success rate, right? But to get there, you have to analyze a lot of data of the population, saying what worked better, right? And
mm,
that is typically data is like three or four kinds in medicine. One is your radiology, your imaging data. One is the labs data. The other is the prescription, etc., the actual case data. The fourth is the research stuff. So until it gets to digital, it happening in the US, other countries, the first step is
mm,
digitization. AI cannot work on paper data, right?
mm,
So
mm,
the changes will be sweeping. If you want to look ahead, it's very difficult. It's
mm,
very dangerous to predict years ahead. But some people
mm,
say that 20 years from now, even a poor farmer in India, you know,
mm,
unfortunately, he gets some kind of a cancer, with a
mm,
with a with a BSc trained personnel who is well versed, who's maybe familiar with some kind of, he can look up the public databases, search, etc., and say this is the. And today, to do that, you need a tumor board of like five senior oncologists, right? So that is not accessible to anybody
mm.
except the
All.
best people. Yeah.
Mm,
So
mm,
that's a promise of AI, that it will make it
mm,
more accessible and affordable. Uh,
mm,
and obviously, there's a lot of thinking about prevention. India itself has a lot of burden of non-communicable diseases like diabetes. If AI can be
mm,
used to look at lifestyle changes, promote awareness, right? Get to people where they are and help them manage their lifestyle. Um, Hopefully, we can prevent the burden on the system 20 years hence.
mm, mm. Do you think that doctors, like in future doctors, they have to be maybe good technocrats also?
No, I think this is the other way around, right? So,
Okay.
so far, the technology challenge and the struggle with doctors has been saying, I'm getting 15 minutes to
Mm,
look at a patient, right? You're making me key
mm,
stuff in, right? I can't make eye
mm,
contact. And it is proven that if a doctor is making eye contact, listening, observing, he will come up with a better diagnosis.
mm,
And
mm,
believe it or not, the empathy he can communicate
mm,
uh, makes a difference to outcomes, right?
mm,
The
mm,
mental well-being of the patient equally important to recovery. Now, the challenge in the
mm,
last decade or so has been saying the more you digitize the
mm,
connections. But now you have ambient technology saying if you and I are talking, the ambient technology will just very precisely capture the conversation, sort out what
okay.
is the diagnosis, what is the prescription, what are the things, case notes, etc., neatly put it in the AMR, right? So the doctor can do
Mm,
what they are doing best, working with the patient, right? Being
mm,
human. Uh, well, I think the technology part is good for
mm,
doctors to know, but I think the
mm,
idea is technology should let them focus on what they're really good at doing, what
Yes.
nobody else can do, right?
Hmm. Hmm.
What nobody
Hmm.
else can. So I think, yeah, reading a chart, reading using a machine is very trivial. They're doing many of these things already, right?
Hmm.
And it's
Hmm.
getting easier. As I said, instead of typing, if I can just
Hmm.
listen and talk, actually
Hmm.
less need to operate technology, more to use technology. So that's what my point of view is.
Hmm.
I think that's the right direction to go.
Hmm. True. 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 So, and the last question, where do you see MedLearn, say, 10 years down the line?
So we expect to be every hospital. I mean, obviously, it's not going to be every, but where we are not today, large, small, government, etc. First is India, of course, and we want to be able
Mm,
to uh, develop solutions that are unique to India. We want this to be, and this is not even take 10 years. We want to establish clear research-based benchmarks saying this is the impact of training on outcomes, right?
mm,
Right?
mm,
Takes time to get there, right? To create benchmarks and industry standards on the best practices. We're already doing it, but hopefully in a little few more years that will be the accepted norm because it's not been done in this country. Uh, Second,
mm,
obviously, we're building more solutions. Even now, we are looking at how do you connect training to employee outcomes? How do you connect training to business and quality outcomes? And we hopefully, with the use of technology, with the understanding of how the ecosystem works, we should be uh, really leading the charge in making Indian healthcare very data driven
mm,
in outcomes and management decisions. I think that's the big term goal. This is just a starting point. Uh,
mm,
this has an impact everywhere, but we want to be the enabler which uses data and technology to hospitals do a much better job.
mm. And I hope that you will penetrate the rural areas also. And I'm sure big hospitals will come up in rural areas also. And I hope the population there also benefits.
Absolutely, absolutely. I think at some time very soon we plan to start working with some of the governments, state
Mm,
government level. I think that will
mm,
start the outreach because right now the presence is, the primary health
mm,
centers, CHCs, PHCs, which are there, and
mm, mm,
define the products for their needs and
mm,
work the system, and then eventually as in when the private folks get there, whatever is the typical hub and spoke model,
mm,
in
mm,
the rural areas, you typically will have the referral model, right? People get screened
mm.
there, etc., etc. So we'll have to develop solutions at that level as well.
Yeah, yeah, yeah. So thank you so much, Mr. Sharma, for talking to me and
Thank you.
giving us all the insights into the technology in healthcare. Thank you
Thank you
so
so much.
much. And I wish you all the best.
Thank you, ma'am.